very much for the introduction, and thank you to NUTRICIA for inviting me along. Very excited to be here. I'm here to talk about something that takes up a lot of my time in clinical practice, house milk allergy. For me, the first question whenever I'm speaking overseas is I always wonder, why do you need to get a doctor all the way from London to come all the way to Istanbul to tell you about allergy? And I think probably the best reason is this. This is the ISO study. So this is an enormous international collaborative study where every few years, hundreds of centres around the world, the prevalence of different allergic diseases is assessed. And it's compared so that we can see how disease patterns are changing over time and how they're appearing in different places. And it's always a very proud moment for me as a British man to be able to show you that the United Kingdom leads the world. We have more allergy than anybody else. And the truth is that in the last 20 or 30 years, our healthcare systems have been almost overwhelmed with the amount of allergy that we're seeing. In fact, it's probably food allergy that's had the biggest impact on our services. There's very clear evidence that there's more allergy around now than there was 20 or 30 years ago. But we've really seen two different epidemics. We've seen an epidemic of genuine increasing food allergy, and we estimate now that in a British pediatric population, probably about 7 or 8% of children will have some sort of food allergy. But if you ask the parents whether they think their child has a food allergy, then you will get statistics like this one. 33% of British parents believe that their child's symptoms, and it could be their dry skin, or their loose stools, or their bad behaviour, or being overweight, or not doing very well at school, all of these things are somehow because of something that they're eating. So this is having an enormous impact in the way that we're having to manage children. I've put a little graph here that just shows the different prevalence of peanut allergy. Peanut allergy is something that gets a lot of interest in the US and the UK, and you can see that even in a very short period of time, we're seeing a significant increase in the amount of peanut allergy that we're seeing. I just wanted to give you a little glimpse of where we think the future might be going with food allergy, because this is an excellent study from Australia where they've always had very similar rates of food allergy to those that we see in Europe and in the West generally. And in this study, they got thousands of children at the age of 12 months, all of whom were simply attending to get their vaccinations performed. So these weren't children from high-risk families, they weren't children with eczema or other allergy problems, these were just unselected children. And all of these children had allergy tests done, and any food they had a positive test to, they were then brought back to the hospital and they were given that food to confirm with absolute certainty were they allergic or not. And this was done 3 or 4 years ago, and these were the numbers that they got. They were able to show a prevalence in an unselected population of over 10% with food allergy. Amongst this population, the most common allergy was egg allergy. And many of the children with egg allergy could eat egg when it was baked in cakes and biscuits. They were fine. It was only a problem when they had plain egg, and usually they outgrew this by the time they were 2 or 3 years of age, so it's not a big problem. But you'll see in here a very significant prevalence of milk allergy, 2.7%. And remember, in this study, they've only looked for immediate type milk allergy. And if you then add on the prevalence of delayed type milk allergies, which we'll talk about, you're looking at a much greater proportion of children suffering from a milk allergy. For me, of all the food allergies, it's milk allergy that's the most interesting, and the reason is it is different to things like peanut allergy or egg allergy because it can show itself in so many different ways. And I've tried to illustrate this here. On the left, you have a child who looks completely normal, but when he has milk, he can have a potentially life-threatening reaction to it, anaphylaxis. Whereas the child on the right has got chronic, ongoing, difficult eczema. Both of them have got a milk allergy. It's a different type of milk allergy. But it's because milk allergy shows itself in these different ways that it causes so much confusion amongst parents and also, unfortunately, amongst the physicians who are meant to be looking after them. You've already seen this diagram. This is just a classification system that differentiates between immune-mediated reactions to food, food allergy, and reactions that don't involve the immune system, food intolerance, which include things like lactose intolerance. But amongst the immune-mediated reactions, amongst food allergy, we also are able to divide a little bit more between the immediate type reactions, IgE-mediated ones, and the delayed type reactions, the non-IgE-mediated, which actually includes a whole range of different gastrointestinal and eczema-related conditions. When we talk to our family doctors in the UK, when we, for example, with the NICE guidelines, the British guidelines, we've broken it down to a very simple system of thinking about milk allergy, of either an immediate type or a delayed type. So with the immediate type, you have rapid reactions very soon after drinking milk. If you're unlucky, it could be an anaphylactic, life-threatening episode. We have a good understanding of the mechanism. We have allergy tests we can do, skin tests or blood tests, and it's quite an easy diagnosis to make. When a mother brings you a child and they say, I gave my child a bottle of milk formula and immediately they came out in hives and I gave them some antihistamine and it got better, it's an easy diagnosis. Whereas also we have these delayed type allergies, the non-IgE, where the child drinks some milk and you don't see anything at all. But if the child is having milk on a regular basis, you start seeing chronic symptoms. But they're symptoms that you commonly see in babies who don't have milk allergy. Eczema, colic, reflux, faltering growth, loose stools, very, very common symptoms. And we don't understand the mechanism. We don't have a good test to do that easily separates out children who just have eczema or reflux from children who have a cow's milk allergy. And so these are very difficult to diagnose. And as a result, unless there's a good understanding of the doctor, unless they've got experience at taking a good allergy history, then these children's diagnosis gets missed and they end up staying unwell for much longer than they need to. Just going to go back to this excellent study. It was performed a long time ago, and it's really just to clarify that, unfortunately, things are not quite as simple as either immediate reaction or delayed reaction. It's a nice way to teach doctors and teach our colleagues about milk allergy, but the reality is a little bit more of a spectrum of disease. So this was carried out in Australia, where they looked at hundreds of children who had reproducible allergic reactions to milk, and they looked at how much milk you needed to give the child before you saw a reaction, what symptoms you saw, and whether you could find IgE, allergic antibody to milk, when you did an allergy test on them. And what they found was not two different groups that were completely distinct from each other. In fact, what they found is there were a group of children who you gave them a very small amount of milk, and very quickly they got symptoms of urticaria or anaphylaxis. These are the IgE-mediated ones. And when you did their allergy test, they had IgE, they're easy. But then you had another group of children who would react 2, 3, 4 hours later with gastrointestinal symptoms or a flare-up of their eczema. And when you looked at their blood, sometimes they had IgE, sometimes not. So they were like an intermediate group. And then you had other children who needed lots of milk on a regular basis, and then they got chronic eczema or gastrointestinal symptoms. And when you looked at their blood, they didn't have IgE. So rather than two distinct groups, the reality of it is that there's a spectrum. And you need to be aware of that, because you will see in your practice these children who are sort of in the middle. And when you try and put them into one box of immediate or the box of delayed, it won't work for you. I'm just going to briefly talk about immediate allergies, just so that I can update you on where we are with these. This is a child having an immediate allergy. He eats the food. Within moments, he notices that he's feeling itchy. He might start rubbing his mouth, his lips, tingling and swelling around the lips, all because of local histamine release. And this is what's going on at the cellular level. This is a mast cell with the IgE to milk on it. The milk protein cross-links the IgE that's bound to the surface of the mast cell. This triggers a signal that goes into the mast cell and leads to the degranulation. So these granules of histamine and the other mediators bind with the cell membrane and release their contents, which go into the bloodstream and the surrounding tissue. They cause capillary vasodilation, capillary leakiness, and that leads to the swelling, the itchiness, and symptoms, for example, like laryngeal edema, and potentially the most worrying one, bronchoconstriction. And in children, it's the bronchoconstriction or laryngeal edema that will cause the small number of fatal reactions that we see. So who gets immediate food allergy? Well, that's easy. It's children with eczema. And the worse your eczema is, and the earlier your eczema starts, the more likely you are to get one of these immediate allergies. So this is a graph showing children divided according to how bad their eczema was during infancy. So these were hundreds of children, 600 or so children, all from very atopic families. So most of them had eczema to some degree. The ones in group 0 had very mild eczema, the ones in group 4 had very bad eczema. All of them at the end of infancy were allergy tested and looked at and carefully examined to see if they had food allergy. And you can see there's a clear relationship. The worse the eczema is, the more likely they get food allergy. Look at this, bad eczema, 65% of them with a food allergy. But this is quite a small study done in a single clinic. This is a much more recently published paper. This was just from a few months ago. This is for over 5,000 children in Australia were assessed. Now, half of these children didn't have eczema. They're in this group. And you can see that amongst the group with no eczema, very few of them get food allergy. Okay? But the children who did have eczema were divided according to how bad their eczema was. So these have got very mild eczema, no need for any topical treatments. These ones just need moisturisers. These ones needed mild steroids. These ones needed strong steroids. So these are the ones with bad eczema. This is during infancy. But they were also divided up according to when their eczema started. So the first groups here, these are the ones where the eczema started less than 3 months, then 3 to 6 months, 7 to 9 months, 10 to 12 months. And you can see a very clear and consistent relationship. The worse the eczema is, the higher the proportion of children who have food allergy. But look at the big difference according to when the eczema started. If your eczema started at less than 3 months and it was severe, your risk of having a food allergy is over 50%. So if you want to find children with food allergies, just look for children with eczema, because a large number of them have food allergy. So we've already seen a little bit about what these immediate reactions look like. They happen quickly, they happen every time the child eats the food that they're allergic to. They're very consistent. The symptoms we see are the same all the time: urticaria, angioedema, and if you're unlucky, more systemic symptoms, and if you're very unlucky, anaphylaxis, so difficulty in breathing, dropping your blood pressure, collapse. The foods that you see will very much relate to your local population. I work in London, so my patients speak over 100 different languages. I see children from all over the world all the time. When I have doctors from overseas, they come to sit in my clinic and they visit, and they all say the same thing to me at the end of the clinic. They say, "Dr. Fox, where are the English people?" Because you just don't see many of them in London. We see people from everywhere else. Okay? Now, what I get is children with allergies to everything you can imagine. The children from India are allergic to chickpeas and lentils. The children from the Middle East are commonly allergic to sesame. The children from Spain are allergic to peaches and fish. But all of the children very commonly get allergy to milk, and they get allergy to egg. And the ones who are from the UK or the US, Australia, lots of peanuts and nut allergies. So which the typical foods are will very much depend on where the child is from. The other thing that we're able to do with these allergies is we can do allergy testing to confirm our diagnosis, which makes my life very easy because I can confirm my suspicion that the child has got that allergy. And when you make a diagnosis of a food allergy, it has an enormous impact on the family. It takes them much longer to do the shopping, even though in the UK the labelling regulations are very, very good, but still it's very difficult. We now have families with iPhone apps that they can scan the barcode of the food to check that it's not got anything they're allergic to in. And it has a real impact on their quality of life. Everything is more difficult. Going out to eat is almost impossible. Going on holidays is difficult. Going to their friends' houses, birthday parties is very difficult for these families. And we worry, of course, about nutrition, especially in the children with milk allergy, that if they're not on the right formula, that they might end up with iron issues, calcium issues. But that's not what the families worry about. What the families worry about is that their child will die because they eat the wrong thing at the wrong time. And although milk allergy is a rare cause of death in children, it is still the main cause, the leading food allergic cause of death in small children. So whilst in teenagers, if you're going to die from your food allergy, it's usually because of a nut allergy or a fish allergy, but in infancy, the deaths that happen in small children, it tends to be milk. Certainly, this is an example of what our parents see, they read about it in the newspaper, so they become very anxious about it. And if you look at children with milk allergy, they do have reactions. However careful the families are, it's inevitable that you're going to have an accident because milk is absolutely everywhere. And in this study from Spain, they showed that amongst almost 100 children with a milk allergy, every year around 40% will have a reaction. Most of those reactions are mild. They are managed with just an antihistamine. But occasionally, a small minority can be very severe. One of these children in the study ended up on an intensive care unit. If you look at who has the bad reactions, it's the children who have both milk allergy and asthma. And having asthma, if you've got an immediate food allergy, is very much the main risk factor for having a more severe reaction. So that's the immediate time allergies. It gets more interesting when we start thinking about the delayed time allergies. That's where it becomes more complicated because it's generally harder to deal with because we don't get the obvious symptoms as soon as you eat the food that you're allergic to. You don't get the story of my child had a bottle of formula and I immediately could tell that there was a problem. That's an immediate allergy. You don't get that. We don't have a good understanding of the prevalence. We know what sorts of numbers to expect from immediate allergies. There just simply hasn't been the work done to understand the number of the prevalence of delayed type allergies. We're sure there's lots more than we're actually picking up. We don't have any real work done to look at the quality of life impact of delayed allergies. More importantly, from a clinical perspective, we don't have any simple tests we can do that just say, yes, this child has a delayed milk allergy. Our regular allergy tests don't work. They only tell us about immediate allergy. And of course, the reason we don't have a good test is because our understanding of the mechanism is not very good. So we don't have, I don't have a nice animation I can show you like I have for the immediate allergy because we simply don't have a good enough handle on the mechanisms. We do, however, know all about the symptoms. This is our British National Guideline, a NICE guideline, and this gives us this long list of symptoms of delayed allergy. But it includes so many symptoms that we see very commonly in children who don't have allergies. Eczema, reflux, abdominal pain, colic, constipation, faltering growth. An enormous number of infants have these symptoms. But which of them have a delayed milk allergy? So we try and classify them to try and make it easier to pick up the patterns that we see in clinic. And this has been confusing because we've had the allergists trying to do this and the gastroenterologists trying to do this. And we've come up with quite different ways of thinking about it. Allergy doctors often talk about food protein-induced proctitis or proctocolitis, food protein-induced enterocolitis syndrome, which is quite a severe form of delayed allergy. But often we also just talk about children with bad eczema, children with colic and reflux. How does it all fit together? It's difficult. If you look at these types of classifications, you can see that actually some of them are probably the same thing, but just a spectrum of severity. And that the child who just gets a small amount of blood in their stool when they're breastfeeding and their mother's drinking milk and just got a bit of proctocolitis is probably a milder version of a child who gets much more severe and immediate impressive symptoms when they're drinking out milk themselves. So we can sort of move on a little bit to this sort of classification, this spectrum of issues that runs for these food protein-induced enterocolitis presentations where within a few hours of drinking milk you see quite impressive abdominal pain, vomiting and diarrhea, to the more chronic presentations of eosinophilic gastrointestinal disease where you can actually do an endoscopy and identify the allergic inflammation in the gut. So probably a lot of overlap, a lot of quite arbitrary distinctions. What we do find though is that the more you head on this side to these types of reactions, the more likely a child is to show up in the office of an allergy doctor, and the more you head towards these chronic symptoms, the more likely they are to present themselves to gastroenterologists. And that's why it's important, because of this overlap, that the specialties are working closely together and talking to each other and doing our research together. If you divide according to that classification those sorts of symptoms, and you look at all the different features, it's extremely difficult to try and differentiate just on the basis of these different symptoms because there's so much overlap. So often what we find we're doing is we're simply talking to each other, to allergists, to gastroenterologists, about delayed food allergy. It's just a spectrum of disease, and each child has their own individual symptoms. But either way, the key is the same for all of them: identifying what the problem food is and excluding it from the diet. And that goes the same for all of these different conditions. And that's when it starts getting difficult, when you have to start identifying which of these children with delayed allergy, or which of these children with these symptoms have these symptoms because of delayed allergy, and which of these children have the symptoms simply because they've got eczema, or they've got reflux, or they've got colic. It's nothing to do with what they're eating. And those are the challenges, because we don't see symptoms happening very quickly. Symptoms are very common in children who don't have allergies, and we don't have any good allergy tests. These are our challenges with diagnosis. So for me, it's all about the history in the first instance. And there's 4 things that I look for when I'm taking the history off a child who I suspect has got a delayed food allergy. The first thing, I'll ask about the atopy in the family already. Is this child from an allergic family? Has the father got asthma and eczema and hay fever? Is there a sibling with an egg allergy? All the things that tell us, does this child have an underlying risk of an allergic problem? And even more reliable than that is, has the child themselves already shown that they've got a problem? So for example, if it's a child with gastrointestinal problems, has the child ever had an obvious reaction to a different food? So for example, an egg allergy. As we saw from that data from Australia, egg allergy is really common, something like 8% of the whole population of children. So if the child's already had an immediate allergy to something, it makes it much more likely that their other problems are also due to allergies, albeit to something else. The next question is treatment resistance. If it's a child with eczema or a child with reflux, have you already tried medicine? Did they work? Because if they didn't respond to treatment the way you expect, it's more likely that there's an underlying cause, an underlying allergy. Dose relationship is very useful. Infants often go from being breastfed to being formula fed. Because milk allergy is the main allergy that we think about in infancy, what happened to the symptoms when the child was moved from having at most a tiny amount of milk through their mother's breast milk to going on to a full formula which is full of calcium and protein? Did the symptoms get worse? Because if they did, it might be because of the increasing amounts of calcium. And then the last one, probably the most important one, is multi-system involvement. Is this a problem with just their gut, or do they also have a problem on their skin? Or if it's a problem with eczema, do they also have gastrointestinal symptoms? Because that is a very, very big clue. Because if you've got symptoms in more than one system, it's much more likely that you've got an allergy. This is work from a hospital in London done many years ago, where they were seeing lots of children with immediate allergies, which they put in group 1, and lots of children with delayed type allergies. And what they noticed is that there were lots of symptoms that they got from the other, typically that you related to the other type of allergy. So for example, the children with delayed allergies in group 2, lots of them, 44% of them, also had eczema. So that's an important clue, because that's way more than you would expect in children with any with other conditions. Lots of them also have easy issues, sort of things you associate again with more immediate type allergies. Interestingly, when you looked at the children with immediate allergies, lots of them had gastrointestinal symptoms as well. There's obviously a lot of crossover in these types. And so this is now reflected in all of our guidelines. So we do have food allergy, but in the eczema guideline, I think they do this much better. They're talking about eczema, but this could equally apply if they were talking about gastrointestinal problems like diarrhea or colic or reflux in children. They say think about food allergy if there's a story of other allergies, so immediate symptoms, or if the problem is moderate to severe rather than mild, so the more severe end, if it isn't controlled by optimal management, so if it's resistant to treatment, and particularly if it's associated with gut dysmotility, so reflux, colic, bowel habit, faltering growth. But likewise, that's because they're talking about children with eczema. If they were talking about children with reflux or colic, they'd say think about food allergy if the child also has eczema. So symptoms of more than one system, very, very important for you. Just wanted to talk a little bit about FPIs, food protein-induced enterocolitis syndrome. It's a bit of a mouthful, but it's getting a lot of interest at the moment because it's one of our emerging new diseases that we're starting to understand a little bit more about. So these are children who when they have an exposure typically in infancy to something like milk or soy, they don't get a rash or swelling or anything like that, but 2 to 6 hours after ingestion, they become very upset, colicky symptoms, and then they get vomiting and diarrhea, sometimes also bloody diarrhea. It's commonly misdiagnosed because these children arrive in the emergency departments looking unwell, looking dehydrated because of the diarrhea and vomiting. They're acidotic, their white cell counts are raised when they have their blood tests done. So they look like sepsis, and quite rightly, they're treated very conservatively, they're put on antibiotics, and nobody really figures out what's going on. It's often, in my experience, the parent who makes the connection of saying, wait a minute, this is actually only the first or second time that they were given formula feed. Previously they've been okay with the breastfed. We've not had any reported deaths, which is good, but it can be very, very unpleasant. When you allergy test, this is a delayed type allergy, so although the reactions happen almost as quickly as an hour or two, it's still a delayed type allergy. It doesn't involve IgE, so usually the allergy test will be negative. And however sick these children are, giving them antihistamines, it doesn't help. It's not about histamine. Giving them adrenaline doesn't help. Giving them ondansetron, because they're vomiting, might help. Giving them steroids doesn't seem to help as much as we want. And it seems to be getting more common. Not many studies looking at prevalence. There's been about 900 reported cases in the literature. We certainly see it regularly in our clinics. The reason that, so this is from an Italian clinic, 1992 to 2004, a doubling in the prevalence. In Australia, 2004 to 2010, tripling in the prevalence. We're probably recognising it better. Whether there's more of it around, we don't really know. If you look at the prevalence studies, we did one in London. It suggested about 0.36% of children had FPIs. In this study from Israel, 0.34%. There was a study from Australia suggesting it's about 0.1%. So it seems to be much less common. But remember, this is a very extreme form of delayed allergy. It's not a whole of delayed allergy. So it doesn't include children who just get a worsening of their eczema or worsening of their reflux when they have cow's milk in their diet. And if you look at these American studies, they show us that, as expected, it's milk that's the most common cause, and that when you look at the children who get it, commonly they just get one food that's an issue, but sometimes there's more than that. There's 2, 3, and sometimes even more than 6 foods involved. If you have a sibling who's got FPIs to something, your risk of getting it is about 8%. So quite significant. So we see lots of sibling pairs. Fortunately, over time, it tends to go away. It actually runs a much better course than the immediate type allergies. It's outgrown earlier. So although we get slightly different results, of course these aren't enormous studies, but for these small studies it suggests that probably about half of them are better by the age of 1, and by the age of 3 most children have outgrown it. If you have, during the course of that period that you've got this diagnosis, get a positive allergy test, chances are it will hang around your allergy and hang around for longer. So that's a bad prognostic sign. Sometimes children who have these delayed type allergies, after a period of exclusion of the milk from their diet, when it's reintroduced, they have an immediate type reaction. So be careful about that. And it's now become our practice in the UK and elsewhere that before you reintroduce back into the diet, you repeat an immediate type allergy test, a skin prick test or a blood test, just to make sure that your family aren't going to get a nasty surprise when you tell them to have a go at trying it again and come out without a fat test, which is very important. I want to just briefly touch on eczema again, and the overlap between food allergy and eczema, because this causes a lot of confusion, mainly because, of course, there's 2 types of allergy that you need to think about when you're dealing with eczema. I've already shown you that data that shows that if you've got eczema in early childhood, there's a good chance that you're going to have an immediate type allergy, and that could be to milk or egg or fish or peanut or any number of things. But what parents are really interested in when they've got an infant with bad eczema is, it's reminding me to come here. What the parents are interested in is, are foods making their eczema worse? So is something in the infant diet, and of course in infancy it's mainly milk that's forming their diet, is the milk contributing to their eczema? Now for many years, doctors simply dismissed this and said to parents, don't be ridiculous, it's nothing to do with the milk. However, the parents always were thinking about this. And in a study some years ago, about 10 years ago, in the UK, it showed that 75% of mothers had been altering the diet and manipulating the diet of their infant to try and make the eczema better. And usually they didn't tell their doctor about it because the doctor just wouldn't take it seriously. But times have changed, and we now understand, and our dermatologists know, that often in the right sort of infants, especially the ones with bad eczema, the ones who have got gastrointestinal symptoms, changing the formula can make an enormous difference. That little video clip was of a child from some years ago who presented to me at 15 months of age. He had bad eczema, he'd been given milk and had a reaction to it. The mother had got so worried about it, she tried giving him goat's milk, which of course caused the same reaction, that she decided she was just going to keep breastfeeding. And by the time she got to our hospital, the child had rickets, just simply because of the anxiety the mother had about the severity of the eczema and the effect of the milk. What parents are often telling us is that when they change their kids' diets, sometimes they do see a clear improvement. But often, if you just increase the amount of steroids, if you just optimise the regular conventional treatment of the eczema, they think that all the foods aren't a problem anymore. It's simply a reflection of the fact that the eczema is just being undertreated. So, as often as not, it's nothing to do with food, but the parents think it is, you just need to treat their eczema properly. But sometimes it is to do with the food. I'm going to give you a case study. This is a child called Jason. Came from a very allergic family, lots of asthma and eczema in the family. Started to get eczema at 2 months of age, it got increasingly severe until they came to our clinic at 5 months of age. And they'd already tried moisturisers, they'd tried weak steroids, wasn't working. So this child had quite treatment-resistant eczema. This child was up all night scratching. Because the child was up scratching, it meant the parents were up scratching. So this family were absolutely miserable. Okay? His growth was faltering, he was passing loose, sometimes mucousy stools on a regular basis. And they were so worried that something in the mother's diet might be a problem that they changed from breastfeeding around 2-3 months of age, where the eczema started, to eventually, by the age of 3 or 4 months, this child was on complete formula feeds. But this child was not doing well, this eczema was very severe. So already, just in that small amount of information, there are lots of clues that would suggest that this might be due to an underlying milk allergy. This child is from an allergic family. His eczema started early, it's severe, it's resistant to treatment, he's got accompanying gastrointestinal symptoms, his growth has started to falter a little bit, and changing from breast to bottle feeding seemed to coincide with a worsening of the symptoms. So there's lots in this story already to suggest that this might be because of an underlying food allergy. Now, we didn't hear it in this story, but it's also worth asking whether the mother's noticed that when she eats certain things and then breastfeeds, does there seem to be a flare-up in the eczema? Because sometimes the parents will be able to identify allergies, not reliably, but sometimes from doing that. Also, if this child had already had a reaction to something else, that would also make it more likely that the eczema was being driven by an allergy. In fact, when we did an allergy test, it was negative to milk, but it was clearly positive to egg. Now, this child didn't have any egg in his diet. He was exclusively bottle-fed. But he had an allergy to egg, which is telling us that you really do need to think about possible milk allergy. Negative allergy test to milk, so it's not an immediate allergy, but of course we already knew that because every day he has 5 bottles of formula and he doesn't come out in hives or swelling. So we already knew there was an immediate allergy. The question we're asking, does he have a delayed allergy? So what happened is it's commonly the situation in the UK. He was put onto an extensively hydrolyzed formula and reviewed a few weeks later. And at the same time, he was put on more potent steroids, which is always a good idea when you're trying to see whether cutting milk out can help. You need to calm the eczema down as well. But then we've got a confusing situation because when we reviewed him a few weeks later, he was better, but he still had significant eczema. Now, was he better because cutting the milk out had really made a difference, or was he better because we just increased the amount of steroids that we put on his skin? It's just not really that clear. And you need to know, has this child got a milk allergy or not? Can he go back onto his regular formula, or does he need to avoid milk? And the problem is that the extensively hydrolyzed formulas have a little bit of milk in them, probably about the same amount of milk as the breast milk of a mother who's consuming milk herself. And we know that this child had eczema when he was exclusively breastfed. So in fact, our intervention is not really provided us with diagnostic clarity. So one of the key things when you're trying to get your diagnosis of delayed allergy is you need a complete milk exclusion. So this child was moved on the suspicion that he did have a milk allergy onto an amino acid formula, completely removed milk from his diet, and then we saw a much clearer response. His stools were much firmer and normalised, the eczema got significantly better, and barely needed any steroids going further, going forward. Now, over time, it might be that he doesn't need an amino acid formula, that he might be able to tolerate something else, but in order to get your diagnosis in the first instance, to avoid diagnostic confusion, my practice is always to completely exclude milk from the diet. Of course, if it's a breastfed mother, it just needs the mother to completely avoid cow's milk in her own diet. So having said that, with all of that knowledge, is it easy to make these diagnoses? Well, I think we've seen very clearly in the UK, where we have lots of milk allergy, that we're not very good at doing this. And that if you look at children with delayed allergies, and how quickly it takes for them to get a diagnosis, commonly there is months of delay. And in fact, in this health economics study, it showed that after presenting to their family doctor, it took on average 18 visits to the GP in the course of a year in order to get properly sorted out. So we're not doing this very effectively. Now, this was a study done in 2010. Since then, we've seen an enormous number of guidelines coming out. These are guidelines from the UK, they're European guidelines, International World Allergy Organization guidelines. There's important guidelines from the United States as well. Lots of different guidelines, all of them saying broadly the same thing, but generally they tend to be enormous documents that a family doctor who only sees the occasional case of food allergy and is more interested in heart disease and diabetes and the things they see more regularly, they're never going to read these sorts of guidelines. So I'm not sure that these guidelines have much impact beyond specialist services where the doctors least need guidelines because they actually know what they're doing. So in the UK, we've developed something called the MAP guideline, the Milk Allergy and Primary Care Guideline. And the focus on this was on mild, particularly delayed type milk allergy, and the focus also particularly was on primary care. This wasn't for specialists, this is for doctors out in the community who see every imaginable problem and see lots of infants with all sorts of issues. And the focus on this, we've been published in numerous places, the focus is algorithms, so simple flowcharts that enable them to look at the right sort of symptoms, make the right decisions about diagnosis, and then make the right treatment decisions. Now, I'm not going to go into this in any detail, it's available free online for clinical and translational allergy, but I think the most interesting aspect of this, for me, having been involved, is the impact that these guidelines have had. And I think this is a message for those of you who are lead opinion in your own countries regarding this sort of area. This is Northern Ireland, this is a region of the United Kingdom, and the reason it's helpful to do work in Northern Ireland is that it's quite separate from the rest of the UK. They've got a relatively small population, so it's 2 million people, about 100,000 babies, small children in the region, of whom we estimate 3,000 or 4,000 will have a cow's milk allergy. And there's a relatively limited number of family doctor practices. There's only 355 of them. And one of my colleagues, Trevor Brown, is the lead author on this work, and what I'm about to show you is in press, it's not yet published. He went round every single one of those 355 practices with those guidelines, and he trained those doctors over a 1 or 2 hour session how to use the guidelines. Okay, he talked to them about recognising milk allergy in infants, about diagnosing it, and about treating it. And so we were able to look within this area what happened from before the training, and then during the training and after the training. Did it change the way that the doctors behaved? Well, it absolutely did. Because what we saw over this 2-year period is a dramatic increase in the number of prescriptions for hypoallergenic formulas. It's very easy for us to get data on the number of prescriptions of hypoallergenic formulas. And you saw an enormous increase. Now, that could be inappropriate overuse of these sorts of formulas. We don't think it is, because we think it's pretty clear that there was significant underdiagnosis of milk allergy beforehand. And the worry, of course, for the people paying for the healthcare is this is just making everything more expensive for us. But what we saw is that at the same time as there was more prescriptions of hypoallergenic formulas, we saw a dramatic drop in prescriptions for things like Gaviscon and omeprazole, and partially hydrolyzed formulas, and comfort formulas, and colic remedies, and all the different things that are given to irritable babies with colic and reflux and things where the doctor doesn't really know what's going on, but they just give the mother something to try and just make them go away and hope that the problem gets better on its own. So in fact, when you took it together, what we found is that the increased cost was only £90, so 150 US dollars per GP practice, a tiny cost. Now remember, we haven't yet looked at the impact on healthcare cost because of the children coming back to the doctor again and again and again and again. And I'm absolutely certain that what we'll find is that the children who were given Gaviscon or colic remedies or lactose-free formulas, they are the ones who keep going back to their doctor because they're not getting better. Whereas the ones who